I hope she can share her screen now.
Yes, please, go ahead.
Dr. Patrick, just let me know when I should start with the introduction, and then we'll start. Good morning.
No. Dr. Miriam,
Yes,
are you there?
Yes, Chief, I'm here. Good morning. Chief, can you hear me?
Yes, we can hear you, Dr. Miriam. Good morning.
Okay.
You can share your screen, and then I'll let you know when to start, Dr. Miriam.
Okay, sir. Sorry, please, can you see my screen?
Yes, we can see your screen. All right. Good morning, esteemed YOs and senior colleagues. I'd like to welcome us to another edition of our webinar series. This morning, we'll be having a presentation on visual field interpretation in glaucoma by Dr. Barminas Miriam, a registrar at the Asokoro District Hospital in Abuja, Nigeria. I'd like us to note our questions. We can send in our questions through the chat boxes and note our questions. And after the presentation, we'll take the questions. Dr. Miriam, please, you can start.
Okay. Thank you very much, sir. Good morning, consultants. Good morning, senior registrars. Good morning, registrars. I'll be leading the discussion this morning on visual field interpretation in glaucoma. Okay, so I'll be doing this using the following line. Introduce the topic, the visual field testing pattern, the test strategies, how to assess a visual field, that's perimetry, and evaluation of a visual field printout, the various field defects in glaucoma, sources of error, and I'll conclude and share my reference. Okay. So visual field, as we all know, is said to be an island of vision, which is surrounded by a sea of darkness. Looking at a particular point in time, there's how far the eye can see even without turning your head to that particular point. So that's what is referred to as a visual field. It's actually the area that is perceived while fixating on a central target. This diagram just depicts the hill, an island of vision, which is surrounded by a sea of darkness, where we see the peak of the hill, which corresponding to the fovea, where we have the maximum vision, and it drops rapidly from 0 to about 3 degrees, and then gradually drops from 3 degrees to about 30 degrees, while drops more rapidly from 30 degrees to onward. That is the peripheral field. So the extension of visual field, it's said to, on looking on a primary position, that's with a target with a central, with a fixation point straight ahead, it's expected that one should see about 50 degrees superiorly, and 60 degree nasally, 70 degree inferiorly, and while the temporal has the highest, about 90 to 100 degree temporally should be seen. And the reason is that temporally, we don't have so much obstruction in our field of vision comparing to the superior, nasal, and inferior. So our blind spot, from this diagram, we know that the blind spot is located nasally, that's the point of the optic nerve, while our center of vision, which is the fovea, it's located temporally. It's important to note this location because when we're interpreting our visual field, that will give us an idea of which eye we're dealing with, and so on, and how the visual field is actually measured. And we should also know that our visual field, the retina, the temporal retina correspond to the nasal visual field, while the nasal retina corresponds to the temporal visual field. That's why on this scale and grayscale picture here, you can see that the blind spot is located temporally. Meanwhile, the optic nerve is nasally. So those are some of the things that we need to take note of. So there are some important terminologies we should be aware of. For example, a scotoma is said to be area of reduced sensitivity, which is surrounded by a more sensitive area. And this is an example of a scotoma in a field of vision, and it can either be absolute or relative. For an absolute scotoma, it's a total area of no vision, which is surrounded by a sensitive area. While in relative, you have like a kind of depressed kind of visual field, but it's not dark, it's not absolute. Vision still have some form of vision, but it's no compared to the absolute, but it's still surrounded with an area of also a relative no vision before you see the area of sensitivity. While depression is said to be area of reduced sensitivity without a normal surrounding area. So that was actually this explanation is for the depression. Sorry. You can see that there's a darker area in this gray region that's referred to as an depression, and usually surrounded with area of also reduced sensitivity, as you can see in the picture. And then for an isota is a threshold line joining points of equal sensitivity on a visual field chart. So for example, on this diagram, we have fixation points, which is here. I don't know if you can see my cursor. These are fixation points, are points of maximum vision, where going onwardly, it is measured in a space of 10 degree difference. And for each retinal sensitivity point on this visual field, with this line actually connects areas that have equal sensitivity in a particular visual field, just as we've seen initially on the island of vision, where the sensitivity dropped from 0 to 3 degrees, from 3 degree to 30 and 32 onward, that's to the peripheral field of view and visual field. So on this, it simply indicates that line joining point of equal sensitivity on the visual field chart. That is known as the eye sector. Then for fixation, this is the part of the visual field which corresponds to the fovea centralis, where we have our maximum vision. So for scotoma, scotoma can be absolute, okay? For absolute scotoma, it's an area of total loss of vision, which is surrounded by the same area, while relative scotoma is an area of reduced or relative loss of vision, which is also surrounded by the same area. So we can either have a scotoma to be a positive or negative scotoma. When we say a scotoma is positive, for example, in this diagram, this is positive scotoma in the sense that the patient can perceive it in the field of vision. But for a negative scotoma, for example, the blind spots, when we're looking at our field of view, we don't notice that we have a blind spot which corresponds to our optic nerve head. So that is referred to as a negative scotoma. So how are these nerve fibers in the retina distributed? Because we also have a direct bearing on the type of defects that can be seen in glaucoma. So it is said that the nasal retina, both the superior and inferior radiating fibers, they sweep directly into the optic nerve head, as seen in this picture. While the macular area, known as the macular bundle, also goes in directly into the optic disc, while the superior and the inferior arcuate fibers make an arc around the macular area before entering the optic nerve head. And this is limited by a horizontal raphe, especially at the temporal area, where these arcuate fibers make an arc around it and end. And so there's no communication between the inferior and the superior fibers. And then this is how they are being arranged in the optic disc. You can see where the macular fibers comes in, and we have the superior temporal fibers. We have the inferior temporal fibers, and then we have the superior nasal and inferior nasal. And all these has implications while interpreting the defects seen in glaucoma visual field. So for the distribution inside the optic nerve, the arrangement of the nerve fibers within the optic nerve head is the deeper fibers comes from the peripheral of the retina, that's from way anteriorly, and they occupy the superficial location of the retina as seen. So it means fibers that are coming from anterior retina, that's closer to the oral serrata, will be more peripheral, and they will also be located at the superficial parts of the optic nerve. And so those that are superficial in the retina, they occupy the central portion of the optic nerve head. So which fibers are most sensitive? And it's said that the arcuate fibers are more susceptible or involved earlier in glaucoma defect. So why do we have arcuate fibers being affected earlier on? So there are two theories to explain why these arcuate fibers are affected earlier. One is the watershed area, where it explains the blood supply to the optic, that's to the inferior and the superior optic nerve head. to have a dual blood supply. And it says when a particular point has dual blood supply, the distal retina, the distal vessels are usually thin. They are usually smaller in caliber and thin. And so if there's any reduced perfusion, the distal area are usually affected most. And so if we can see this diagram, we can see both superior and the inferior parts of the optic disc are being supplied by these dual vasculatures. And it says that they're usually smaller and thinner in caliber, and with reduced perfusion, this area are more at risk to ischemia than the temporal and the nasal. And precisely, it says the superior temporal and the inferior temporal. Those are the areas that are usually affected. And then the second theory is the pulse theory, where it talks about the amount of connective tissues that are found in the superior and inferior optic nerve head. If we look at this diagram, we see that the pores on the superior and inferior optic nerve head are more larger compared to the temporal and the nasal part. And that means that then we have a reduced supportive network, connective tissue in that area. And so with any increase in intraocular pressure, this pressure can be transmitted more to those areas than the nasal and the superior part. And therefore, using the nerve fibers entering the optic nerve head, those areas at ischemic condition. So how do we assess visual field? Visual field is actually assessed through the use of perimetry, which is said to be a subjective examination method to assess the visual field, and is a functional test where you test the function of the visual field. With the idea of the extension of how far one can see in looking in a straightforward position. For the visual field is actually divided into the central and the periphery. The central visual field is actually from 0 to 30 degrees. So from this way, from this eye software, we have the central visual field. And that's what we majorly assess when we're doing visual field, especially in glaucoma. Then from 40 onward, we have the peripheral visual field. And then there's also the Jerome's area, which is a visual field around the 25. Instead of the 30, which is the central, we reduce it further to the 25-degree point. That is known as the Jerome area. And that's where mostly we have the accurate and fibers being tested. So generally, perimetry is classified into either automated static perimetry or manual kinetic perimetry. And then the gold standard is now the automated static perimetry. And the manual kinetic perimetry is rarely used now. Confrontational visual field, which is another way of assessing the visual field, can be done on bedside or at the clinic. So that's a quick way of having an idea of what the visual field is. And this will be more practical if, especially when the patient has a tunnel vision, because and it's really more subjective compared to the automated static perimetry, in the sense that you're assuming the person taking the confrontational visual field, that your own visual field is normal. So perimetry, in automated perimetry, a constant size stimulus. So when you're doing your perimetry, there should be a constant size stimulus. You don't vary the size. And it's given against a constant background illumination. It's presented in varied light intensity at particular points according to a testing strategy. And the minimum intensity necessary for the dictation of the stimulus is recorded as the threshold of that particular point. So this is a diagram of an automated perimetry machine. This is where the chin rests, the patient rests their forehead there. At the right position, we focus on a target given in the machine, and there's a constant background illumination in the machine and a constant size stimulus, which can be selected, is given. And while you vary light intensity at a particular point, and then the minimum intensity necessary for the patient to be able to detect the stimulus is referred to as the threshold light of that particular point of the retina. So when we say a fixation target can be a central fixation target or a fixation diamond, which can be some machine. Well, most of the machines I have seen, they mostly have a central fixation target, which can either be a round yellow cycle on a white background, but other machines use a diamond shape to be the fixation point. And then the background illumination, we said it should be constant. For the Humphrey 700, it uses a background illumination of about 31.5 apostles units, while that of the octopus, which are the two most common standard automated perimetry, the octopus use a background illumination of 31.4. So that's just a difference between 0.1 illumination. Okay, so for the stimulus size, there are different types of size and different sizes that can be used. And this was actually developed by Professor Franz Goldman, and it gives target size of from 0 to 5. The most widely used is the size 3, which is about 4 millimeter square. And you can see the various sizes of the stimuli in relations to the optic head disc, where we see the 5 being the largest, followed by the 4, and then this the 3, which is mostly used in testing for visual field. So for the stimulus intensity, how do we measure the stimulus intensity? It is the light intensity usually expressed either in apostles or in decibels units, while the retinal sensitivity is measured in decibel units. The light stimulus, which can be attenuated using attenuation filters, like we said, you present the stimulus in varied intensity. So that is being achieved by using the attenuation filters to do that. And the attenuation of light is expressed in logarithmic units, and that is referred to as the decibel. So this is a scale showing the relationship between the decibel and apostles. They have an inverse kind of relationship. They have an inverse kind of relationship where the higher the apostles, the lower the decibels. And then the retinal sensitivity has a direct kind of relationship with the decibels. Thus, it means that when we're measuring retinal sensitivity, we actually use decibels. When we said that the patient has a good or a high retinal sensitivity, it means that he was able to perceive the dimmest light that was presented at that particular point of the retina. For example, when you present a 50 decibels and light intensity, which is referred to as the dimmest light, and the patient is able to perceive it at that point, it means that the retina has a very high retinal sensitivity, and that is giving a score of 50. While when you present the brightest light intensity, and yet the patient could not perceive it, that is referred to as low retinal sensitivity or no retinal sensitivity, and is giving the score of 0 decibels. So when we come to light threshold, like we said, the light intensity given to the patient varied in intensity. So for a threshold light, it refers to the dim light presented to a particular point of the retina, and the patient is able to identify or perceive 50% of the time when that same light threshold is given to that particular point. That is referred to as the light threshold. But in supra threshold, you give a brightest light, and you expect that the patient should be able to perceive this light more than 50% of the time. While in infra threshold, you present the dimmest light and you expect the patient to perceive it in less than 50% of the time. That's the light threshold. And then, as you can see here, these are the raw data being plotted for different retinal sensitivity at different points in time, given with their raw score as given on the chart. So how do we, for the testing pattern, the testing pattern indicates the extent at which you are measuring a visual field. And like I said, in glaucoma visual field test, we mostly use the central visual field. So the example of testing patterns include, we have 30-2, 24-2, 10-2, macular programming, and then we have the nasal step. So when we say -2, there's a difference between -1 and -2 in the sense that in -1 central field, the points, some of the points are actually found on the vertical and horizontal lines. And so that becomes difficult when you are trying to analyze these results, because these points that are located at the vertical and the horizontal lines, you won't know which of the field should be attributed to. So that's why the -2 central field is preferred, because the points are not found on this vertical and horizontal line. Rather, they straddle this line of fixation. And so you know particularly which side of the field this point belongs to. And so when we say 30-2, we mean that you're testing the central 30-degree of the field, as seen in this diagram. And then for 24-2, it means that you're testing up to the 24-degree of the visual field. But by nasally, you still increase it to 30, because of one of the early changes in glaucoma is the nasal step. So you don't want to exclude that part of the visual field. Why was it reduced from 30 to 24? That can reduce the testing time, because it was saying that and what a 30-2 visual field results can give you, you can also get it from a 24-2 central threshold test. So it's, rather than doing a 30-2, it's preferable you do a 24-2, which can give you a relatively similar result, but still measuring the that nasal aspect that is very important in detecting one of the earliest defects seen in glaucoma. So the 10-2 means you're measuring just about the 10 degree visual field, while the macular programming is just about the 5-degree visual field you're measuring, and usually done especially in an advanced stage of the disease. And then there's also a testing pattern just to test the nasal step, like I said, which is indicated in as one of the earlier changes seen in glaucoma field. So, for the different testing patterns, for 30-2, it actually tests about 76 points, and the point density is about 6 degrees. And then the bare area for fixation spot is about 3. So, for example, if we do a 30-1, you can see where our fixation point is. And this central area is very critical when testing for visual field. So what you intend to do is to reduce the bare area also, apart from the points and being on the fixation line. You want to also reduce this bare area. That's bare area means the area in between points, because usually the machine is, because you don't test all points of the retina, it tests a particular point and then extrapolate for those bare areas. So for the central visual field, especially the central 5 to 10 degrees, is very important. So you want to also reduce the bare area in that test. And then for 24-2, like I said, it's actually from 30-2. You can see how it excludes on these other periphery test points, especially at the temporal area, including the 24-degree visual field. But in the nasal area, it still extends up to 30 degrees. That's for 24-2. And it tests about 54. So there's decreased points of test. And then point density is still about 6 degrees. And then the bare area is also 3 degrees, just like in 30-2. So for 10-2 central visual and threshold tests, usually in 24-2, you measure only 12 points. But when you concentrate on the 10-2 central test pattern, you increase the test points, but a smaller visual field. And so these are usually used in people that are confirmed to have glaucoma already, and you want to test the function of the central 10-degree vision. So it tests about 68 points. The point density is increased. It's about 2 degrees. And then the bare area is just 1 degree. So you can see how very resolute, how high resolute in testing the points on the retina using the 10-2. And then for the macular programming, it tests about the central 16.5 degrees from the fixation. And then total point extension is about 5 degrees, as we said. The point density is 2 degrees, and then the bare area is just 1 degree. The nasal step explore peripheral field from 30 degrees to 50 degrees. So it's actually a peripheral test from 30, 40, and 50. Total point tested is about 14, and it provides 2 eccentric points and points being tested either above and below the horizontal axis. So that's it for the test pattern. For the test strategy is, okay, you have a particular pattern that you want to test the patient. So how do you present this light stimulus to this retinal point, and for you to be able to dictate if there's any scotoma in that area? So first, we have the standard or the full threshold strategy. which actually use the staircasing or bracketing strategy, where first of all, you present a particular point with the brightest light stimulus, and then you decrease it by 4 decibels and see the point at which the patient cannot perceive the stimulus. At that point that the patient cannot perceive the stimulus, you start increasing the light intensity by 2 decibels. At the point which the patient is able to have the first perception of that point, that will be the threshold. That's how the full threshold strategy works. The disadvantage of this is the fact that it takes more time, and then this test needs a maximum cooperation and attention of the patient. Using a full threshold strategy in a patient that is not paying attention might not yield the right results that you want. And so there are other faster test strategies that has been developed. But for people that you really need to know the extent of their visual field, not just whether there is a loss of retinal sensitivity, but you also want to know how deep it is. You will need the full threshold. Then the fast pack strategy actually decreased the full threshold by 40%. And then it follows a similar staircase pattern. But in this case, instead of reducing it by 4 decibel, it actually does that by 3 decibel, thereby reducing the time of the test with about 40%. While the Swedish interactive thresholding algorithm, known as the SITA, it's actually more of a logical and forecasting and rapidly adaptive software that is used to extrapolate how you can be able to do this test faster. So there's the SITA standard, which reduced the full threshold by about 50% time. And then the SITA fast, additional 30% reduction in time. And then we have the SITA faster, which takes only 2 minutes for an eye to finish an examination. But of course, when you use some of these faster strategy, that will be at how will I put it now? The quality of the visual field, that may be compromised when you use the faster test strategy. So we've seen the testing patterns, the strategy we use in presenting the stimulus to the patient. And now, how do we systematically evaluate a visual field printout? So, and the visual field printout can be separated into various zones, which can help us in interpreting the result. So first is the patient data and the test data, which are very important. Like we said, this automated machine, they actually have an age control data that are being input in them to help in comparing the patient you're testing and the assumed normal data that this machine has. And then we have the zone 2, where we have the reliability indices and the fovea threshold. Zone 3, where we have the road data. Zone 4, the grayscale, while zone 5 and 6, we have the total deviation numerical plot and its probability plot. Zone 7 and 8, we have the pattern deviation numerical plot and its probability plot. And then zone 9, we have the global indices. And zone 10, we have the glaucoma hemifield test. So this slide is to putting side by side the printout from an optical machine versus a home-free field analyzer. We can see that there's not much difference. It's just that the opticals usually use more of colors, especially when it comes to the raw data. So you can extrapolate with this color, you can extrapolate what the raw data would be at that area, while the Humphrey actually gives you the raw data on the scale. And then another thing to note again is that while we have a Bebie curve in the octopus, usually most of the times we don't see a Bebie curve in the Humphrey. So that's just to put side by side the different the printouts of octopus and Humphrey field analyzer. So first, you want to identify this patient and test data. Patient's name is important for identification. Date of birth and age, it's very, very important, because any mistake in the age of the patients can give a wrong analysis. Like we said, there is an age control data already in this machine that is used in comparing the patient to the normal population. So if you put, for example, a patient is about 50-year-old and you're putting 30-year-old, that's a great difference. The analysis you'll be doing on the field will not be appropriate. And then pupil diameter is also important. It says the optimal pupil should be about 3 to 4 millimeter in diameter. If you have a small pupil, especially people that are less than 3 millimeters to 2 millimeters, you will have an edge scotoma. And then for visual acuity, it's good to have an idea what the visual acuity of this patient. Imagine sending a patient with probably hand movements, or even counting finger might be able to do a visual acuity, but hand movements, the patient will not be able to do this test. And the refractive error correction for a near vision is very important, because we know that this test is usually done at like a 30 centimeter distance. So if the patient is having a near correction, they need to put on the near correction. Or some machine comes with a space where you can put in the near correction for the patient and then allow them to test for that particular eye. Usually advisable to use the place provided to slot in the near correction of the patient, because if they use their glasses, sometimes you can have a rim scotoma, where the rim of the glasses, depending on how thick it is, can block some points that the patient will not be able to identify, and that will give a. Okay, so for the test data, we have the fixation monitor, where we have the blind spots. This area shows you how well the patient has been fixating. For you to have an effective visual field test result, the patient must continually fixate on the target and not miss the fixation point. And so some machine comes with some software to dictate when a patient is not fixating, and can automatically pause the test or alert the perimetrist so that they can adjust the patient test or encourage them to keep fixating on the fixation point. And it is important because that point actually correspond to the blind spot, and it's also occasionally tested by the machine by presenting light stimulus at that point and see if the patient will perceive it. Once the patient is able to perceive light at that point, it means that the patient is not fixating, because the patient is not supposed to perceive it. And then the color of the stimulus, some use white, but others use yellow on white and background. And then we have the background illumination, like this for Humphrey. For octopus, it's about 3 and 31.4. And then the fixation target, which is central stimulus size, the Goldman size 3, which mostly used on Humphrey. And then the threshold test pattern, either 30-2, 24-2, 10-2, and so on. And then the testing strategy, is very important also, whether you're doing a full threshold, a fast path, or a SITA. So this slide is just showing us the fact that correcting for the person refractive error is very important. Make sure that the person is wearing their correction, especially for near vision. You can see there was like a generalized depressed retinal sensitivity when the patient didn't use their correction, and then you can see how the field became so after the right correction was given. Okay, thank you. So for also pupillary diameter, we said this is an example when the pupillary diameter was just about 2 millimeters and when it was around 3 millimeters. You can see the edge is photomatic. So the checking of reliability indices is very important. Like we said that for the fixation loss, occasionally the machine can present point to the optic nerve and then see if the patient can perceive. Once they are able to click that they perceive, it means that the patient is not fixating properly. And then for most machines, and a fixation loss of greater than 20 is unreliable. Some said 15 to 20, some say greater than 20. It's unreliable. It means the test is unreliable. And then for false negative, for gaze tracking, you can see this graph here. This place is tracking the gaze. The upward deflection actually means that there's loss of fixation. And then the downward stroke means when the patient blinks. So for false negative, usually picked on the printouts where when you start the test, the machine actually presents like light intensity, especially at 4 cardinal points in the 4 quadrants. So for example, imagine presenting this initial light intensity and the patient is able to perceive them and click and record it in the machine that they've seen it. And then subsequently onward, the patient will not see any other point. This will give you what we know as cloverleaf visual field. And usually it gives a very high false negative test in the sense that the patient was not attentive or the patient was tired and fatigued and so couldn't participate in the test. And then it's usually, once the value is with more than 20, it says to be unreliable. And then for false positive, they are usually called happy trigger patients. And this is because just based on the sound of the stimulus, it just by the sound, they keep clicking and claiming that they can perceive those light intensity. Meanwhile, they can't perceive it. So most machines, you can actually off those sounds of presenting the stimulus so that the patient wouldn't know when to and all that. So for happy trigger patient, that's trigger happy patient, what you see on the printout on the grayscale is that you see some white scotomas. So how about the raw data section or the zone? The raw data zone is just the numerical display of this each retinal sensitivity of a particular point on the retina. So it's presented as the absolute value at which the patient is able to perceive the light. And then the grayscale, it represents the numerical display and is usually meant for patient education. It's not usually really used for clinical interpretation. It's just to show the patient that, okay, this darker area that you're seeing means that you can't see anything there. It's just to educate the patient. And this grayscale is usually based on extrapolation, since it's not all test points that are being tested. So it's extrapolated based on changes of about 5 decibel units. And as we know, the foveola had the highest points of sensitivity. And so by extrapolating 5 decibel periphery, you'll be able to have your grayscale. Then for total deviation numerical pattern, this is just comparing your raw data of the patient with the age control already in the machine. So what you do is, for example, this for the normal retinal sensitivity of this particular patient age group, and then this is the patient retinal sensitivity. All you need to do is to minus that of the patient from the normal, and that gets your total deviation numerical pattern. And then for the total deviation probability plot is using the total deviation numerical pattern that you've gotten above to calculate the statistical significance of every of those deviation numerical points that you've gotten. So once you do that, there are symbols attached to it. Okay, so for example, if the statistical significance is less than 5, which means this abnormality is seen in less than 5% of the population. So the lower the p-value, the probability value, the more its clinical significance. That's why the less than 0.5% is signified to a total, like an absolute scotoma, where we see the face. So if we say that if the probability value is less than 0.5, it means that it's unlikely that it's a normal finding in a general or a normal population, which means that there's something wrong with that point. And then the pattern deviation numerical plot is gotten from the total deviation numerical plot, in the sense that this helps in bringing out localized or deep localized defects or scotomas in the visual field. That's after you've corrected for any maybe lens opacity, vitreous opacity. After correcting for that, then you have like a localized defect. How do we do that? That is usually done by you arrange. Thank God, the machine does all this for us, but we need to have an idea how the machine does it. So it's arranged the total deviation numerical points in increasing order. So for example, here we have 0, we have -1, we have -2. You arrange it like that, and then the 7th best deviation numerical plots will now be used to convert to be minus from the patient's total deviation numerical plot, numerical plot. So for example, this was about, I think, -5 was the best 7th value that was picked, and as you can see, -5 minus 12 will give you -17, and so on. So once you do this, usually what you aim is that you reduce the deviation from the normal. So what it does is that some points we still retain the deviation from the normal population, while some points will become 0 and they will now be less of significance, have lesser probability value, and so will not be significant. So those points that still retain their p-value of higher value, those will now be the localized defects that will be seen in subsequently. So For example, for the total deviation numerical plots, you can see for the probability plot, you can see how we have probability of less than 0.5%, even superior and inferior. But when you corrected for the deviation, now you can see that it's giving us more of like a superior kind of accurate defects on it. So what about the global indices? We have the mean deviation or defect, pattern standard deviation, short-term fluctuation. Then we have the corrected pattern standard deviation, visual field index. So the mean deviation is average of all the values of the total deviation numerical plots, and it's compared to the reference field. So negative, and you can have a negative and a positive value, and minus or negative value is actually bad, in the sense that it means that the average sensitivity of the retina has gotten worse, as in it has it's of negative, in the sense that it has a deficit of compared to the normal age group of that particular patient. While the pattern standard deviation reflects the degree of departure of the measured visual field pattern from the normal field of vision. As we can see from this diagram, we can see that from the upper values refers to the age control of that age, and then we can see that of the patient that has been measured, while the middle red ones refers to the standard deviation from the normal. While these points, they just have like 0 standard deviation, but here they have about 1 and 3. So that is it. And for this pattern standard deviation is actually known as a low variance in octopus machine. Then for short-term fluctuation, we have it's usually used in full threshold strategy. The threshold of about 10 selected retinal points are checked twice, and the variability is noted in these 10 points. And if the value is greater than 3, it shows that there is a low reliability of the patient to the response of this light intensity. So for corrected pattern standard deviation, this is usually done by removing the short-term fluctuation from the pattern standard deviation, and that gives the corrected pattern standard deviation. However, it's not superior to PSA. For visual field index, is usually an indication for measuring progression. With decreasing value, we tend to have indicates that there is progression in this patient. It's actually calculated from the pattern deviation numerical pattern, and this generally indicate the percentage of the retinal sensitivity of the patient compared to the normal retinal sensitivity for that age. So for glaucoma hemifield test, it actually compare the 5 groups of corresponding test points in the superior and inferior field, and it's more of like an mirror image location of these 5 different zones, and it's in. And the zones are constructed in approximate patterns of the nerve fibers, and it can detect glaucomatous field defect at a very early stage. And so you have either the result is outside normal limits, whether it's abnormally high sensitivity or within normal limits. Sorry, am I still audible?
Yes, you have. Please round up.
Thank you, sir. Okay. So for Bebie curve, it's this one just give a quick assessment of the defects in the characteristics and depth of a defect. So for example, this diffuse, we either have a diffuse or focal defect. For a diffuse, we see a curve below and it's parallel to the normal curve. While in a steep fall off, we usually have a a fall to the right of the curve. Then, so these glaucomatous field defects can be classified into non-specific field and specific field defects. The specific field, we have the early, late, and then the advanced cases. So for early non-specific defects, we can see an eye subtle contraction where there is contraction of both the central and the peripheral field. And then while we have the barring of the blind spot, barring of the blind spot just simply means that excluding the blind spot from the visual field. And then enlargement of blind spots also can also be seen. A normal blind spot is located 15 degree temporal and is about 6 degree wide in width and then 8 degree in height. So anything other than that shows that there's enlargement of the spot. And then for the early significant defects, we include the paracentral scotoma, which we can see. And then we have the sedal sickle shape, where there's an enlargement of blind spots meeting the paracentral scotoma. And then the nasal step, which we said is very important in MESH as one of the early changes, is just more of a periphery field defect. And then the late specific changes include the arcuate or germ scotoma, ring or double arcuate scotoma. And then we have the running nasal and central nasal step, which is just this step that is seen nasally. And it happens because there's asymmetric defect between the inferior and the inferior arcuate fibers. And then for advanced changes, we have the tubular vision, the temporal island of vision, which can be seen here, and then the complete visual defect, where there's no light perception in this patient. So these are some of the visual field defects in glaucoma. These are just some examples. Then, so after interpreting your result, taking note of all those zones, so how do you classify this patient? We do that by using the Addison classification system, where you can take time and just go through it. Then what are some of the sources of errors in visual field testing? First, the patient's refraction. We've said that pupil size, lens rim artifact, media opacity, when there is ptosis, inadequate retinal adaptation, especially when you just do the testing after oculonoscopy, patient not paying attention. And then from the perimetry side, you can though this is not so important for automated perimetry, but it's good that you instruct the patient so that the patient understands this test before you start it. And then also encourage the patient that it's not all stimuli that they will be able to perceive. And in addition, the perimetry should explain to the patient how to pause the test if necessary. And then incorrect patient details can also affect the test. So this is just a lens rim artifact. And then when the patient has ptosis and when the lid was taped up, and see the improvements in the visual field. So when interpreting fields, one should first assess their reliability, then determine the likelihood that they are demonstrating pathology. And this information will be helpful in formulating a treatment strategy. And glaucoma defects are focal, thus we need to take note, and progression is the hallmark of the disease. So there's also a need for a serial test and then comparing for progression. And then clinical correlation is very, very important. What you're seeing in your field defect, is it corresponding to what you're seeing on your optic disc and the patient's presentation? Okay. These are some of my references, and thank you so much for your time listening.
Thank you so much, Dr. Miriam, for a very detailed and robust presentation. One of the best I've actually listened to on visual field interpretation. You've done so well. While we await more questions and comments, I'd like to say that, just give a quick summary. She introduced, telling us of the relevant anatomy, And she told us about testing patterns and thresholding algorithms, the different types and the reasons for each of those patterns and algorithms. And then she also told us how a visual field printout should be interpreted. So let me just lay some emphasis here. As she did say, you should make sure that the printout you have in your hand is that of the patient and that the details are correctly imputed. Details in terms of age, sex, any refractive error used, any refractive correction used, because this is very important in analyzing the results we obtain. And I also want to quickly add that when you want to interpret the visual field for any individual, you hold the printout for both eyes in your hand. The printout for the patient's right eye should be in your right hand, while that of the patient's left eye should be in your left hand. And then you analyze. And she did mention you need to look at the reliability indices to be sure you can go ahead to interpret. You can rely on the results of that test. And then she emphasized the importance of correlating the findings on the visual field printout with clinical findings. Okay, so let's quickly go to the chat to see the comments and questions that are there. Okay. Dr. Simon wants you to go over the reliability indices once more. Just hold on. Okay. There's a question about fixation monitor off, what it means. Okay. All right, so this is how I'm going to go about it. For those of us that wanted to go over some aspects, like the chairman already said, the recording will be made available so we can go over it to be clearer on reliability indices and the scotoma section. However, Dr. Miriam, I'd like you to quickly go over the pattern standard deviation a little. So for Oronta Marachi, she wants to just elucidate a little bit more on pattern standard deviation. And then Dr. Olatude wants to elucidate a little more about testing strategies. And if you can quickly do that, maybe in the next 2 to 3 minutes, and then we'll take comments from our senior colleagues, and then we'll call it a day.
Thank you, sir. So for the pattern standard deviation pattern, is actually gotten from the total deviation numerical plot, in the sense that you're trying to correct for any field defect that is due to other pathology other than glaucoma. So how does the machine do that? It's picked out the seventh best pattern total deviation. So it can arrange the retinal, that's the pattern and the total deviation in increasing order, and then you picked the seventh best. That's the seventh and total deviation. Once you pick that, you try to neutralize it to be 0. That's to be there's no deviation. And then that value, what you do is that you minus that value from each of the total numerical deviation values. Once you minus it, what it does is that it makes some points to become clinically insignificant. That's the probability value to drop, to not be significant, while some other points are 0, and then some other points still retain their probability value. That's their p-value of less than 0.5. So all those points that still retain their p-values of less than 0.5 are significant. And so in a way, it will localize the defects instead of just being seen a general kind of defects when you've not figured out whether there's cataract in this patient, whether there's other media opacity in this patient. So the pattern standard deviation just helps in in localizing the defects. I don't know if that is clear.
Hello, good
I
morning.
believe. Okay. Please.
Hello, good morning.
Good morning.
Morning.
Good morning, Chief. Good morning, sir.
This is a very, very wonderful presentation, and really, the presenter has shown that the presenter has done a very good homework. She has gone to the level of how the machine works, the physics and everything. That is quite commendable. And so I just want to say one or two words,
Please go ahead, sir.
especially with regards to the last question. She has mentioned the technical part. So what does it mean in the simpler terms, a common layman's language? If somebody has glaucoma, he could have cataract, he could have refractive errors, he can have every other things. Now you want to be sure this field defect is from the optic nerve, not from those things. So let's assume in contribution of cataract, refractive error, vitreous opacity to his visual field is minus, let's say minus 2.5. So if you take this from all the reading, what you'll be left with is the local. So it's just giving you the local distance. So that's what it means. It subtract all the other things and give you, and that is a pattern deviation now, not the pattern standard deviation. That's the pattern deviation plot. So one of the slides, you will see that in the total deviation, you see so many dark spots. But in the PSD, it just localized it because it removed all that from cataract, refractive errors and others. So that's about the pattern deviation plots. Not about the pattern standard deviation from our mathematics. We know pattern standard deviation. So if you have 3 poor people, if you take the average weight, it will not tell you, it just give you the average, but it won't tell you how is their weight differ from one another. So if you have like 3 people of the same weight, if you take their average and minus their weight, it will be 0 because they are all the same. But if somebody is 100 kg, another person is 5 kg, another person is 3 kg, and you take the average and then come and be minusing each person's weight from the mean. So the difference, it will tell you maybe if the mean is 10 and then my weight is 70, so you see the difference. If another person's weight is 20 and you minus 10, so it tells you the level of the difference in affectations. It's not really uniform. And in early glaucoma, PSD may initially be high because not all points are affected equally. But as the disease progresses, more points are becoming affected. The less affected one becoming deeper affected, and there's uniformity in the affectation. So the pattern standard deviation may decide to go down. And that is why in some field, you will see that it's even completely extinguished. So by and large, it's a very good presentation. Doctor, you have done very well, and we're expecting you in the glaucoma.
Thank you, sir.
Yes, good one. Keep it up.
Thank you very much, sir, for your comments. And thank you very much for commending her. As we round up, I want to appreciate our very senior colleagues that took time to join us for today's webinar. As was announced earlier, the recording will be made available very shortly so that we can all go over it again and digest the stuff that Dr. Miriam gave us this morning. There's a question about reliability indices. She did mention that for standard automated perimetry, for the unfreeze, false positive and false negative said to be reliable for values greater than 33%, and fixation losses at values greater than 20%. While for SITA strategies, false positive and false negative will deem to be not so reliable once it's greater than 15%. So I think at that point, we can call it a day. I also, once again, want to appreciate Dr. Miriam for a wonderful presentation and appreciate every one of us for making our time to participate in today's webinar. Hope to see us all in Kano, August 27 to 29. Thank you very much. Have a blessed weekend.
Thank
Bye.
you, sir.
Thank you.